Suitcase Club, everyone. Today we have the topic, the big C, when tissue biopsies yield unexpected results. And this is going to be presented by Charlotte. I just put in a very short little bit about Charlotte, a picture. And she is the head of parasitology at the reference laboratory for the set of emerging zoonotic and parasitic diseases at the NICD. And on the invite that we sent out, there was actually a nice CV that went out with that as well. So you can always go back and look at that. We are coming to you from our practice in Rosebank, so Fire Station Rosebank, and that's where we are, and a few of our staff members there. Just a little bit about the Suitcase Club. If you guys have been joining, you've heard this already before. But basically what we're trying to do is sort of gather a bit of information, a bit of data about travel-related illnesses through GeoSentinel. And GeoSentinel is a joint venture between the ISTM and the CDC. And we basically act as the center in Johannesburg, with there being, I think, the other one in Cape Town. And there's a couple others, but not that many in Africa. And it's good for us to just get a bit of data if we have any ill-return travelers, so people that are returning from outside the borders of South Africa. And it's a form that needs to be filled out, and then we do the submission on your behalf. So anyone can submit a case. It just is done through us. And this is a little bit on their website. And if you are going to submit a case, there's an email address that you can email or call us. Contact any of us, we can assist with that, travel related. A bit about our vaccines that we have. This is our Section 21 shingles vaccine. Obviously, since Zostavac's no longer available in South Africa, this is the only available vaccine. We have an online form that can be filled in just as for application, and then one of our nursing staff usually gets hold of the potential clients and just figures out when we can actually see you to give the vaccine. So that's brought in under Section 21. Then the other thing we bring in under Section 21 is our mefloquine, and that is, we were also bringing in the pediatric Malaron. We now have a local stock of that, but we do have the online forms for pediatric malaria, pregnant malaria, and also any travelers who are coming through that need malaria prophylaxis. So we will attend to all of those. Just a little quick thank you to MSD for providing us with some lovely snackies. And I'm actually going to hand over now to Pam from MSD. She's going to give us a few slides just on Gardasil and that's great. Thanks, Pam. So you can come have a seat here.
Hi, everyone. So I'm Pam from MSD. I'm the rep for Joburg North. I look after up to Potchefstroom, a bit of Nelspruit. If anybody needs contact, you can just ask Dr. Sam, and I can always give you the rep in the area. I just want to talk a little bit about Gardasil 9 this evening. I'm sure you're all aware there was a Gardasil 4. We've recently brought out Gardasil 9, which just has broader cover. And we just want to get everyone on board because we feel that the fight against HPV is for all of us. The more coverage we get, I think we're going to reach our aim of less cervical cancer quicker. As you know, everyone is at risk of HPV. More than 95% of cervical cancer cases are caused by HPV. And there's over 40 HPV types. It can infect the genital tract. There's low-risk genotypes, which cause warts, and then the cancer ones that you know of 16 and 18. So the WHO's goal is a big one. So that's why I say we all need to be on board. The targets must be met by 2030, and they want 90% of girls fully vaccinated by the age of 15 years. Now, in South Africa, they do have a school program. They are giving the bivalent vaccine, and they're only giving 1 dose. And we all know in South African setup, 1 dose is not enough. So in the private practice, MSD is very active in the private schools. We're getting nurses involved. We're doing activations at mines and wherever we can just to get the vaccine in the arm. The WHO also wants 70% of women screened, tested by 35 years and again at 45. And we know that people are just not going for pap smears. And that's why cervical cancer is killing so many of our girls. And they want 90% of women identified with cervical disease to receive treatment. And in government, it's just not happening. So yeah, it's a big ask, but we're going to try our best. So because HPV affects 80% of people over the course of their lifetime without discrimination, it's girls and boys of all ages. It's transmitted sexually, either vaginally, anal, or oral, non-sexually with your fomites, and your non-sexual with your babies being born during vaginal delivery, and then post-birth contact with the mom or the relative. So it's everywhere. According to the South African Cervical Cancer Prevention and Control Policy, they say cervical cancer is the second most common cancer among women after breast cancer. So there's a lot more cases of breast cancer, but it's picked up quickly and people go for treatment. Not so many are going for pap smears, and then by the time it is picked up, it's usually a central lesion and it's too late. This is South African data, just to show you there. Look how much more cervical cancer mortality rate is versus sort of the lung. It's really, really high. So cervical first, your breast second, and then your colon and your rectum third, going down to your ovaries. And then the bottom block for me is very scary. This is annual number of new cervical cancer cases in South Africa. And look at the ages of how young they are. 30 to 39. I mean, that's the moms of young children. 40 to 49. That's the working, it's, 50 to 59. That's us. So that's leaving little orphans behind. It's really, really scary. It's our workforce. Yeah. And we're picking them up younger and younger. This is just showing the 10 most frequent oncogenic types, and out of that, Gardasil 9 covers 9 of them. 16 and 18 are your most dangerous ones that are usually found, and they go for surgery quite quickly after that. But what's nice is with Gardasil 9, there's no age cutoff. And even if you get an abnormal pap smear, you would still vaccinate. It's not going to treat the current infection that you've got, but it's going to prevent further infection, because chances are we don't know if the partner you're with is reinfecting you. So at least you'll be prevented then from the other types. So you're 16 and 18, you're 33. 45 is becoming very common. We're seeing the gynaes and they're saying they're seeing a lot of 45s. And then you're 52 and 58. So MSD needs to now, well, they are busy working on more and more strains to be covered, but I think with the 9, you're covering a nice chunk of the oncogenic types. And then your 6 and 11 at the bottom is your genital warts. With seeing all these doctors, we're hearing about a lot of throat and neck cancers caused by HPV, and the anaesthetists are seeing a lot of warts in the throat as well. So the minute they go to intubate, they're seeing the warts. So what's nice is your Gardasil 9 covers your warts as well. So for years, there was always Gardasil 4, just covered your HPV 6 and 11 for the warts, and 16 and 18 for your cancer. Now they've added the extra 5. Both are still available. A lot of the men are using Gardasil 4, and then the ladies the 9. Eventually, MSD will stop producing the 4. We're one of the few countries that still has Gardasil 4. Price-wise, there is a huge difference. Your Gardasil 4, you're looking at 1,000 Rand a dose, and your Gardasil 9 is 2,000. So, yeah, a lot of the medical aids are on board. Unfortunately, not Discovery. So if anyone's got friends in Discovery, please let me know. GEMS is covering BankMed, Platinum Health. All of them are taking it out of their risk benefit. That doesn't come out of their savings. So the small little independent guys, but your big Medi-Helps and your Discovery comes out of the savings. Crazy, and
Prof Med?
Prof Med is paying. This is just showing you what's all affected. We've spoken about the cervical cancer, the 16 and the 18. And this is just to show you over time what the efficacy is of Gardasil. It's got very, very high cover for your cervical cancer, persistent infections, your SIN 2 and 3 lesions, and then your genital warts. So over time, they don't see you having to need a booster vaccine. Quickly going through the schedule. It's for girls and boys from the age of 9. 9 to 14-year-olds have 2 doses. They must have 2 doses within 13 months. The soonest they can have their second dose is at 5, but they've got 13 months to give the second dose. So what's nice is with the medical age, you can always do one in the one year and the second one in the second year. And then your adult is 3 doses, months 1, 2 months later, and 6 months after the first dose. But again, as long as they have 3 doses in a year, we're happy with that. And then, yeah, we're widening the umbrella of effective protection. We're trying to do adolescents in the schools, the ages between 25 and 45, and then our older ladies, anyone from 30 upwards. So we're targeting everyone.
Older.
Our older ones. So yeah, no age cutoff. So yeah, I'm just encouraging in all your clinics to please just have the HPV conversation, and if they haven't had the Gardasil, to maybe just plant the seed. Thank you very much. Any questions? Well,
I know of 2 film stars that got throat cancer, and I think one of them died last week. So it's, that to me is always, that's real. And then the other bit of news is we've been recording the ISTM podcast about vaccines. And one of the big messages is that there's no such thing as a travel vaccines. Everybody should have every vaccine. And so HPV should be in a travel clinic and should be talked about, because that's your opportunity to make a public health intervention. Thank you very much.
Okay, well, good afternoon, everyone. I'm Charlotte, as Sam mentioned, and I work at the NICD. So I actually started at the NICD in parasitology mid-2022, having taken over some of the reins from Professor John Freen, that you all know, and who's currently here in the room. And since then, actually been privileged to see quite a few interesting cases with him. So I'm going to present some of them here, share some of them here with you today. Interestingly, we've just had some discussion around cancer. And so I've named this the Big C because it's some of the cases where cancer was one of the, or top of the differential, but the tissue biopsies yielded unexpected results in these patients. So just upfront, a big thank you to the clinicians and the pathologists who refer these cases to us, and then to the staff at the parasitology lab at the NICD, the scientists and the technologists for helping us make the diagnoses on these. So let's jump into the first case. I have 4. So shortly after I started, we had a referral from Cape Town, a patient who is 82-year-old male, presenting with a 5-year history, so quite a long history, of 3 small non-healing ulcers, and you can see the images there on his right upper arm. The largest one was about 2 centimeters by 1 centimeters. Relatively painless, no regional lymphadenopathy, and no systemic symptoms. And he lived just outside of Cape Town, presented to, I think, a healthcare practitioner in Cape Town. And I know we have some dermatologists in the room and maybe on the call. So if there are any questions or any thoughts at this point, very brief presentation, but obviously, I think because of the chronic nature, and because of the age of the patient, perhaps we don't really know what the patient did in terms of occupation. It was an exposed area of the body. I think cutaneous malignancy was part of the differential. So a biopsy was done. And here you have an image. It's an H&E image of a tissue section from this patient. And you see a lot of cells and there's some inflammation. But what I've ringed there in red is in the center, you can see these vacuolated cells, these larger cells that are empty looking in the middle. And you can see some, if you can appreciate some small blue dots, that's really good. So that's basically what the biopsy showed. Any more thoughts at this point? So patient from Cape Town presenting with chronic non-healing ulcers with a tissue biopsy that's showing some intracellular small blue dots. A great question. So that was the thing, you know, where had he been to? Had he traveled anywhere? And yes, indeed, he had. And he remembers having traveled to near Karasburg in Namibia about 5 years previously. So just, you know, shortly before, or not too long before the lesion started. And he remembered being bitten by what he thought was a mosquito when he was in Namibia, Karasburg. So I think the penny is dropping now. And so for the tissue sample that was sent to us for which these small intracellular organisms were identified, we could actually subject that to a molecular test, so PCR. And then you can see the PCR product there, which showed that this was actually positive or products that was the same size as a Leishmania product, and we sequenced that and it came up as Leishmania tropica. So this patient had cutaneous leishmaniasis, and the causative agent is Leishmania tropica. And then subsequently, actually, I think Prof. Freen had been following up this patient with a clinician. He was actually treated with fluconazole, and two of the three lesions, as you can see on the top, did resolve, but the third lesion actually looked a bit worse and wasn't resolving. And unfortunately, he then went to a plastic surgeon that excised it. So it's not really the recommendation for these lesions. They can be difficult to treat and they can take a long time. So we do need to have some patience. And then we didn't have any further follow-up on him. But, you know, sometimes these lesions can break down following excision. So that was the first case, cutaneous leishmaniasis in a patient who traveled to Namibia. Which brings us to case 2 then, in October 2023, a patient from Durban, a very respected dermatologist, seen this patient, 62-year-old male, presented with a lesion on the left upper arm, quite a small one. The patient said he had actually noticed a bump on the arm at the end of June. It wasn't painful, it wasn't itchy. And when you look at the lesion, you probably think, why was he actually worried about it? And I'll show you a picture. But it's because he's got a history of actinic keratosis and he had previous excisions for which he had nodular basal cell carcinoma diagnosed. So again, he was worried about a cancer recurrence, otherwise quite well. So I had to read around and remind myself about nodular basal cell carcinoma and what it normally looks like. So apparently it can start off like a pimple and then it can become translucent and you can see some telangiectasia around it. Eventually it will grow and ulcerate and have these typical rolled edges. Okay, but when you see the picture of this patient's lesion on the left, it was actually still like a pink flesh-colored papule, wasn't translucent. They didn't see any telangiectasia and wasn't ulcerated. And then the picture on the right is what it looked like under dermoscopy. And I can't say anything further because I'm not an expert, but I think the darker patch is where that corresponds to where the lesion is. So although it wasn't typical for basal cell carcinoma, a biopsy was performed, obviously to see what was going on. And here you see a lot of pink and purple again. So this is a picture, a low powered image of the tissue biopsy. And if you are here, you can appreciate there's lots of inflammation. So all those little dots are nuclei of cells. And at this level, all you can tell is that on the lower right-hand side is the dermis, and then moving towards the left is the deeper dermis. So he had a lot of chronic inflammation involving the superficial and the deep dermis. And if you go down in high power, if you can appreciate here again, can you see these empty looking areas? So within all of the other inflammation, these larger, rounded, more empty looking vacuolated cells, histiocytes. And I can see someone already pointing out to, she can see little dots. Okay, so these intracytoplasmic organisms and these little dots, blue dots. And if you go in much higher power, it's a bit blurred, but you can appreciate more in the center there, that round, this round cell, the histiocyte, and you can see these little intracellular organisms, and they're actually sitting around the rim of this vacuolated histiocyte or macrophage. And that's actually something the histopathologists term the marquee sign. So marquee, and it took me a long time to figure out why they called it that, but this is a mirror like the Hollywood stars use with the light bulbs around. It's called a marquee mirror, or like I think those tents that used to have with those marquee lights. And so that's why they call it the marquee sign. And while it's not like 100% specific, it's quite indicative of leishmaniasis. And you can see another nice big one here sitting at the top. So usually you would want to see as well a small dot and dash. So the nucleus and the kinetoplast of the mastigote of the leishmania within, but it's very hard. If you can maybe with the eye of faith see it there. So the size, the location, and the morphology of this was very much in keeping with leishmaniasis. So remember, that's what the histopathologist reported it as, in keeping with cutaneous leishmaniasis, and then subsequently sent us a tissue, and we then via molecular means also diagnosed Leishmania tropica. But before even the histopathologist, well, before we got to the diagnosis, the dermatologist got that initial histopathology report with cutaneous leishmaniasis, and he was like, this is totally unexpected. It's not what I was thinking at all. I said to the histopathologist, can you make sure and go back and check that you haven't mixed up the specimens? Okay, which the histopathologist duly did and said, no, definitely no specimen mix up. But then the histopathologist called us at parasitology, and almost at the same time, the dermatologist called Prof. Bloomberg. And then I got the histopathologist call, and then shortly thereafter, a message from Lucille saying, there's this case in KZN. And I was like, yes, I know, I've just spoken to the histopathologist. But the dermatologist wasn't convinced because it was so unexpected. So they sent them to us, and we confirmed molecularly. So dermatologists went back and asked the patient for travel history, and he had traveled most recently to Maputo in Mozambique, and he had stayed at a lovely resort, and he had given a very nice description of where he stayed. It was upmarket, situated on the top of a dune. It was quite windy and cold when he was there. He walked on the beach, just relaxed. He didn't notice any mosquitoes or flies. He slept with a net. He said most evenings and afternoons, there were fairly strong shore winds. It was quite a big house. All the surroundings were paved and grassed. And he felt, if anything, he was far more likely to have been bitten in the cozy area in northern Natal than in Mozambique, which was a bit, when we got this history, then a little bit unexpected for us. Because as far as we know, there's no leishmania in South Africa or Mozambique. But we do know from our previous case as well that there's leishmania in Namibia. So we went back and we asked, and lo and behold, the patient sent us a lovely itinerary of his Namibia trip. So that's all the places that he had been, and it's absolutely wonderful. He was such a good historian that the year before he had been to Namibia, and it looked like a fantastic trip, and he was so organized. I mean, when you look at the menu he had planned for his breakfast, I was like, even as I was reading it, I was thinking, oh, Milo and rusks and bacon and eggs, it sounds divine. And then he was going to see wild horses somewhere as well. So it was absolutely fantastic. And I think when you follow it, you'll see that he had traveled, from here, Bloemfontein, all the way up to what seems like to Swakopmund and then back again. So he had certainly been in the area where that other previous case we had diagnosed had been. So we think that he was probably also exposed in the southeastern part of Namibia. And he was then, he was then treated with a whole lot of different regimens. He was given ketoconazole first. The dermatologist had been discussing this with other colleagues in India. So they started on antifungals, and actually, paradoxically, the lesions seemed to get worse rather than get better. So that is what is known about cutaneous leishmaniasis. Extremely difficult to treat. Different lesions caused by different species can respond variably to treatment, and you have to give it a long time to see some evidence of response. And paradoxically, lesions do tend to get worse before they get better. But I think the patient was anxious, and so they changed treatment a few times. He was given cryotherapy and then laser therapy, and eventually we were liaising the whole time with the WHO experts that Lucille had put us in contact with to try and see what they would recommend, and we eventually managed to get intralesional antimonials for him. By that time, the patient was quite frustrated and had decided he was just going to leave it. He didn't want to expose himself to potential side effects, and he decided not to take any further treatment.
And having fallen amongst dermatologists, did he never get cortisone?
Well, so he didn't, but we'll wait till the next case. So just these two cases then, obviously, of patients who presented in South Africa but had traveled to Namibia where they most likely were exposed. And there is a paper that I'll show you now where there have been about less than 40 cases described from the rural southern Namibian area near the Keetmanshoop area mostly. And that was published several decades ago. I think it was 1992. And that was at the time where we didn't have these molecular tools to properly identify. And it was probably thought to be Leishmania ethiopica, which is a closely related species to Tropica, that these hyraxes or those rock dassies were implicated as the major reservoirs. And the sandflies were the vectors, but there wasn't fully investigated. But I mean, Prof. Reen will know better. There was a master student, Ian Davidson, an entomologist, who did then do some work in looking at the vector and the distribution. I think all those shaded gray areas is where he found the vector. So Prof. Reen has shared these lovely images. That's the paper. And these images are paintings, watercolor paintings, which portray the landscape in that area. And you can see these are the rocky outcroppings where those hyraxes live. And Prof. Reen's also shared that these paintings are actually done by Adolf Jentsch, who's clinical microbiologist Uta Jentsch's grandfather or distant relative, who lived in Namibia between the 1930s and 1950s. And he was a well-known prolific watercolorist in the area. So those are the first two cases. So let's go on to the third case. In December, a few months after the second case, where we had a 69-year-old male patient presenting to one of our colleagues, we all know Dr. Evan Shaw here in Johannesburg, with this non-healing forehead lesion. He had seen previous healthcare workers, if I remember correctly, and he had been given a steroid cream to apply on his lesion. I don't know if it's a dermatologist by somebody. And I think he had also been given, I think the differential was, is this bacterial, is this something else? He was given a lot of different treatments, and it just got worse. And especially after the steroid treatment, it got worse. And then he was referred to a plastic surgeon who then performed a biopsy. Thankfully, didn't cut it out, but performed a biopsy. And let's see if I can advance. Okay, here we go. So just to point you to that's the whole description of the histopathology report. But again, you could see there's this background inflammation and the possibility of intracellular organisms were considered. So that they were thinking, could this be a malignancy? But again, they're seeing something potentially infectious. And the histopathologist there said, highly worrisome for an intracellular fungal infection, and did a whole lot of stains, a PAS, DPAS, GROCOT. These are all for fungal organisms, and they were all negative. A Zeal-Nielsen just to exclude any acid-fast bacilli, and a gram stain for bacteria. So any thoughts or any questions that you'd like to ask? Yeah, exactly. So before that, they actually did a interesting stain on the tissue, a CD1A, which is not 100% sensitive, and I'm not going to go into the technicalities, but if it comes up positive on the intracellular organism, it's highly suggestive for leishmaniasis. So that was done, but then the tissue was also then sent to us for confirmation. And we then confirmed Leishmania infantum. So it wasn't a fungus after all, it was Leishmania infantum in a patient presenting to Dr. Shaw in Johannesburg. So to answer the question in the room, where had he traveled to? And he had traveled to Mallorca off the coast of Spain the previous year. So, and then when we Googled it, actually, there have been reports of other returning travelers who had been to Mallorca, which is in the Mediterranean basin, quite a popular tourist spot. A cutaneous leishmaniasis in a German patient returning after vacation in Mallorca. And actually, when you go on to and read further and you look at this heat map of Spain, you can see all along the Mediterranean coast, especially, and also the Balearic Islands, the red is where they're seeing a lot of leishmaniasis in dogs, canine leishmaniasis. So obviously dogs are the reservoir animals, and sandflies are the vectors in this region, and human cases then occur. And more recently, there's been this interesting article, if you want to read more, the group from Sweden had observed about 8 to 9 cases of leishmaniasis in a group of patients who went to a rehab center in Spain. Now, all of these patients were on biological treatments for rheumatic diseases, and they went off to this rehab center in Spain, which just so happened to be situated in an area endemic for leishmaniasis. And about 10% of them actually then presented with cutaneous leishmaniasis, and one actually with visceral leishmaniasis. So the thing about infantum is that can cause both cutaneous and visceral leishmaniasis, and obviously visceral is more serious condition. So that's really interesting. So that's Leishmania infantum related to travel to Mallorca in Spain. Now that patient, we've actually found an article where infantum was treated successfully with an antifungal called posaconazole, which has relatively fewer side effects, and especially because it was on the forehead. Some follow-up from Dr. Shaw was that the patient, he had to motivate for it, but the patient did eventually get it and did seem to respond to posaconazole. So really interesting. So that was the third case of leishmania where cancer was a consideration, but turned out to be an infectious cause. So this is the final case, a 69-year-old female who came through, and this was late last year, presented to the dermatologist in Bloemfontein, chronic lesions on the nose, as you can see there. She actually also had difficulty breathing, a lot of nasal stuffiness, but very indurated, and had been there for almost a year. She had worked in the Northern Cape. She had been helping her children run a lodge or manage a lodge in the Northern Cape. And she had never traveled outside of South Africa. And she presented to many previous healthcare providers, including a dermatologist who had done a biopsy many months before. They had seen lots of inflammation, and one of the reports queried leishmaniasis, but nothing further was acted on at that point. And then she had obviously presented again to this dermatologist in Bloemfontein. So a tissue biopsy was done. And the arrows point to, again, what you can see look like little small round blue dots within the histiocytes. But remember, she had never traveled outside of South Africa. And as we've seen on the WHO maps, there is no leishmania in South Africa. So, any thoughts? So we just wanted to know, where was this lodge in the Northern Cape that she had worked on? And it was between these two places. I think it was Griquastad and I can't even remember now, and I can't even read it. Groblershoop, yeah. So between there, somewhere between there, was this lodge that she had been on for many years, and she had recently returned from Bloemfontein. And here you can see the border of South Africa and Namibia, but she had never traveled beyond this. Okay, so and interestingly enough, the patient herself, interestingly enough, the patient herself said to the dermatologist, she thinks she's got these lesions because of the dassies on the farm.
Wow.
Because there's so many on the farm that the farmer actually shoots them to try and cull them, which is terrible. But apparently that's what she said. And if you know that dassies can be a host for animal host for leishmania, and the sandflies actually like feeding on the snouts or the noses of these poor dassies, and that's the sandfly sitting there. So it was quite interesting that she had made that observation to the dermatologist, because when the tissue came to us, came back as Leishmania tropica, which was very interesting with on the background that she had never traveled. And we don't think sandflies can travel that far. They're very small, 1 to 3 millimeters. I don't think they can travel that far. So yeah, so this was really interesting for us. And actually, she then got miltefosine, WHO donated drug that was available in Johannesburg for another case, not leishmania case, which we managed to get to the dermatologist in Bloemfontein. And you can see it's so much better in terms of the induration. She was actually better able to breathe. Yes, it may look worse because there's a lot of scabbing and scarring, but that's re-epithelialization, and all of that is a sign of improvement. So she actually is doing and progressing quite well on miltefosine, which was great. So what do we know about leishmania in South Africa? According to the WHO details, there is no human leishmania in South Africa. There have been reports of leishmaniasis in sheep in the Eastern Transvaal and dogs as well, imported. But if you go back into the literature, actually, in this one paper, and I can't actually get the original reference, was that there was a single case of cutaneous leishmaniasis in a human in Okip in the Northern Cape many, many decades ago. And I don't have any more information on that. And the only thing I know about Okip is it's a small town, and in the 1870s, it was ranked as having the richest copper mine in the world. But again, you can see Okip is very close to the border with Namibia, and not too, and probably the same latitude of where her lodge was. So it probably speaks to that the ecosystem, the landscape, the geography, the vectors and the reservoir hosts are probably in that area. And actually, anecdotally, we've had some dermatologists and actually some ID clinicians say dermatologists from the Free State and the Northern Cape have anecdotally seen cases of leishmaniasis, but they've never actually been confirmed. So what we're doing at the NICD is we've teamed up with a team at Honest Report that we're there doing research on midges to capture some sandflies for us, which we now have, to try and see if we can isolate any leishmania from sandflies in that area. And we're probably going to have to do a similar thing with people who deal with hyraxes and do some kind of clinical information gathering as well, to try and piece it all together. But those were the 4 cases in which the chronic lesions and cutaneous leishmaniasis was not expected. So instead of the big C cancer, it's actually maybe the small c cutaneous leishmaniasis. So just a little bit on leishmania. I don't know how much of time we have, but it consists of a complex of vector-borne diseases. It's a group of protozoa that belong to the genus Leishmania, and it's transmitted by the female sandfly vector, phlebotomine in, I think, Asia and Africa, and Lutzomia in the Americas. And here is a life cycle showing the stages of in the sandfly, and then transmission to human through the sandfly bite, and then the mastigotes, which multiply in the cells that you saw in those tissue biopsies. And then obviously when a sandfly feeds again, takes a blood meal, gets infected, and the whole cycle is repeated. So this is showing that you can have human to human transmission. So where the human hosts are the main, humans are the main hosts, or zoonotic, like we've seen with reservoir hosts being like hyraxes and canids like dogs. And here's just a classification showing the different genus and subgenus and all the different complexes. So Leishmania can become quite complex, but I think the main thing here is to point out is that you need to, the subgenus and the species identification is really important because it helps guide therapy. The clinical presentations can range from cutaneous ulcers, like you see in the pictures there, A, to systemic multi-organ disease, like you see in visceral leishmaniasis. So cutaneous are usually the most common, usually ulcers that have that appearance where they have like a raised edge and a central crater. Some of them can scab over, and they can be quite painless. Some can be painful, and some people may have swollen glands near the sores in the armpits, for example. The second image there shows mucocutaneous, which can affect the mouth, the nose, and the throat. And then visceral, which is the most serious form, because almost always, if you don't treat these patients, will die. And these patients usually present with fever, loss of weight, enlarged spleen and liver. Usually the spleen is larger than the liver, and they can have pancytopenia. And then some patients can develop this post, they also call visceral leishmaniasis Kala-Azar or black disease. Patients can develop this post-Kala-Azar dermal leishmaniasis as well. And then obviously in certain areas where visceral leishmaniasis and HIV overlap, it's becoming quite important opportunistic infection in these areas. And the specific organisms are frequently associated with a typical clinical picture, but this can be variable, and I'll show you in the table. So here, these are the main species or genuses that cause the different presentations. So here we had, if you look, we had the cases of L. tropica from Namibia. That's usually associated with cutaneous leishmaniasis. But the case from Spain, which was infantum, if you look at infantum, it can cause both visceral and cutaneous leishmaniasis. So depending on the species that you identify, you really need to follow your patient up closely to make sure that they don't go on to develop other symptoms, or that you assess them properly. And then a differential of cutaneous leishmaniasis, I think, is important. And I think in many of these were considered, is this a bacterial infection? Could it be things like cutaneous myiasis or other infectious causes? Especially things like mycobacterial cutaneous TB and non-mycobacterial, non-TB mycobacteria, such as Mycobacterium marinum or Buruli ulcer. You'd also think about fungal infections, like the dimorphics or the deep fungal infections like Sporothrix or Blasto. But malignancy is obviously included in that differential, and then autoimmune diseases like sarcoidosis, and the list is much longer. But they say clinical features that can help differentiate cutaneous leishmaniasis from these others include the chronicity of the lesions, so they can be there for many, many years. They're generally painless. They can cluster, so they usually occur where the sandfly feeds, so they can cluster, and they occur on exposed locations because sandflies have very delicate biting parts. They can't really bite through thick clothing or whatever. So it's usually on exposed skin. And then sometimes the orientation of the skin lesions along skin creases can give a point towards cutaneous leishmaniasis. And so just some global statistics. It affects leishmaniasis affects some of the world's poorest people. It's associated with malnutrition, population displacement, poor housing, weak immune systems. It's about 1 million new cases that are estimated to occur every year. And then just to note that only a small fraction of those infected by parasites will actually develop the disease, because it's an interplay between the species type and the host immunity as well. WHO has published some maps in 2023. If you want to look at the global epidemiology of where visceral leishmaniasis occurs, and then you can see that there's no local cases in Southern Africa. And then if you look at where cutaneous leishmania occurs, you'll see that Namibia is colored in, but there's been no reported cases for the year 2022. And then if you want to just, it's a summary, it's usually 88 countries, about 350 million people live in the areas where they're at risk. And most of these countries are in the tropics and subtropics. So the rainforests from Central and South America all the way to the deserts in West Asia. And then the countries listed there are basically where most of these cases occur. And then just to note that more than 90% of the world's cases of visceral leishmaniasis occur in India, Bangladesh, Nepal, Sudan, and Brazil. The diagnosis we talked about, and it's generally a touch prep or a smear, tissue biopsy, so histopathology. Culture, we can't routinely culture leishmania here. Even at parasitology lab, we wouldn't do it. It is possible, but I think it's difficult. Serology doesn't really have a place, but I suppose in visceral leishmaniasis you could use it. We don't offer that here. And then obviously the newer molecular techniques that we've shown you. This is what touch prep would look like. It's not really advancing now. There you go. But you can't see it on the screen.
Maybe it's just, it's like it's,
yeah. Okay. So that's what we've seen, those intracellular small blue dots. Now, not everything that is intracellular and small and blue is leishmania, unfortunately. So for the histopathologist, there is a differential based on the morphology and the size. So leishmania usually has that dot and dash of the nucleus and the kinetoplast, but difficult to appreciate usually. Other things like histoplasma, and in our context, emergomyces can look very similar. Trypanosoma cruzi, which we don't see like Chagas disease, but that can look similar. Microsporidia as well as Toxoplasma gondii. So treatment options, just basic principles. You want to treat cutaneous leishmaniasis to prevent morbidity. There are local therapies based on how many lesions, the size, which site of the body is affected, and then you have to balance the risks with the benefits with the toxicity and the costs and availability of treatment. There's all of these other treatments that have now been maybe suggested, like thermotherapy, cryotherapy, intralesional drugs. But for mucocutaneous leishmaniasis, especially if you in South America and the subgenus Viana, because they cause mucocutaneous leishmaniasis, you need to give more aggressive systemic therapy. And then for patients with visceral leishmaniasis, systemic agents like miltefosine and amphotericin B have been suggested. But treatment is complicated and it can have a rocky course. So just in terms of prevention, if you're advising travelers, there are no vaccines or drugs to prevent the infection, but the CDC Yellow Book says travelers can reduce the risk by using personal protective measures to avoid sandfly contact and bites. So, I mean, if you're on holiday, not to go out between dusk and dawn is difficult sometimes, especially if you're, suppose, in the Mediterranean, but to avoid outdoor activities where possible during these times where the sandflies are the most active, wear protective clothing. Apply insect repellents, especially to the skin that's exposed and under the edges of clothing. Sleep in air-conditioned or well-screened areas. Can try insecticides, and then fans or ventilate. Other like aircons may inhibit the movement of sandflies because they're weak flyers. So they definitely can't travel from Namibia to the Northern Cape. But they're usually small, 2 to 3 millimeters. So important to note that they can pass through the holes in ordinary mosquito nets. So you can get finer mesh nets, but apparently those are quite uncomfortable to sleep under. So the mosquito nets that are treated with, like, for example, permethrin can be effective. And you can apply that to bed sheets and clothing as well. So just in conclusion, that cutaneous leishmaniasis, although very uncommon, should be considered in patients with one or more chronic skin lesions and a history of exposure in an area where leishmaniasis is endemic. A definitive diagnosis is needed. You need to see the demonstration of the parasite in the tissue by histology, and now we have molecular analysis, PCR and sequencing, and that to get a diagnosis to the level of species is really important and should be pursued because this information influences how you manage treatment and follow up patients. And I think that's it from me. Thank you.
Thank you, Charlotte. Yeah. I'm gonna just ask the audience if there's any questions from there. You can either type or just unmute or raise your hands. But in the room so long, do we have any? Yes.
Antifungals. Topical treatment? No, it's antimonials, John. Hey, intralesional. So yeah. Topical antifungals are not effective. Pterosin B is available, and that's why most people will then try fluconazole as well, because that's available. But it's usually, yeah, orally. No, nothing that's effective. There's intralesional drugs, the antimonials, that are also not available locally, and we'd have to make an application through the WHO to donate drugs, which have been done, and we've managed to acquire it for the case in Durban, but at that point he didn't want to proceed with that. And these drugs do have local effects and side effects that patients may not want to
So if you use fluconazole already then, for how long? What's the dose?
Yeah, also quite difficult. So it's usually between 200 and 400 milligrams and for weeks on end. So 4 to 6 weeks, and you have to reassess. But I think in just these few number of cases, we have seen that fluconazole has not really been that effective. And so when we had that 4th case, the patient with the nasal lesions, and it was confirmed, I think we decided we should just do as recommended, which is the miltefosine for that patient, which is orally taken, and that we managed to get that because there was some leftover stock from a previous case in Johannesburg, and she actually responded well to it. So they do say that fluconazole and the antifungals, depending on the species type, the response to treatment is variable. And I think from the few cases that we've seen, fluconazole doesn't seem to work that well. They even say that even if it's the same species, but if the geography differs, the response to treatment may differ. So it's quite complex. And you have to be patient. Patients may feel that it's getting worse, and sometimes it getting worse before it's getting better is actually a sign that the treatment is working.
So that, okay, they have also been treated with topical steroids.
The last case had also been treated with topical steroids. And I think the lesions then got a bit worse on steroids.
That was going to be my question.
Yeah.
But then does it make it worse? Like
It does seem to make it worse from those 2 cases that received topical steroids.
So just something that I think you really brought out, Charlotte, is immune suppressed people are more prone to get Salazar, visceral, but the immunologicals you mentioned, and I mean that right up just there, and we are seeing an enormous amount of people on immunologicals here, which we always ask about because of the live vaccines with like yellow fever.
Right.
And every Tom, Dick, and Harry seems to be describing it to every Tom, Dick, and Harry. And this is
it's not uncommon at all.
What was the rehab center for?
I think for patients who had some form of rheumatic disease. I suppose it was, I didn't know why they would go there, but maybe it's sun and
So it's not for alcohol or drugs.
No, for patients who had a rehab center for rheumatic diseases. Yeah,
Like
just unfortunate. Yeah, exactly. Just unfortunate it was in an area that was endemic for leishmaniasis.
And just just to be clear, so do we not have the sandflies in the Northern Cape? Because we've got the
do.
dust and we've got the
We
sand.
do. We have the vectors and we have the potential reservoir animal hosts. So it's completely possible that the patient 4 was exposed and infected in the Northern Cape. It's probably the only possibility, actually. Yeah.
Yeah, because you said sandflies can't fly that far, but I mean,
Yeah,
they are there, and they're not going to respect the border. So the leishmaniasis could have spread.
We
So
well,
you must
we
write
know.
that up as
Well,
out of-
it is one of. I mean, because it has some public health significance, if documenting the first case or confirmed case in South Africa, we are looking at then the vector, the host, and then some clinical follow-up in that area. So like I said, watch this space. We are going to extract DNA from the sandflies that we've received and then test them for leishmania.
And the dussies?
We still need to link in with people who are DASI or Hyrax experts. We're trying to find those people.
This lady, this one.
Environment, the Northern Cape environment, very similar to the Southern
Exactly the
It's
same.
insane. Exactly.
So it's probably shared environment. We've been there all along.
Yeah.
And I think the thing is, people may get lesions and they may spontaneously heal. So just important to mention that people may be infected and spontaneously heal. So maybe people have been having these lesions, just not presenting to care, or they've been presenting to care and haven't been recognized. And so we need to investigate a bit further. Or climate change could be playing a role as well. Who knows? It's interesting.
I don't have any questions online, so I'm going to close the online part, but we're welcome to just continue chatting in the room. Thank you everyone who joined, and we'll see you next month.